Thanks, Amit. Thanks, AIOS. You set up a fantastic debate in all of these, and there have been some wonderful talks. Both Dr. Rupali and Monica are fantastic glaucoma specialists, and they have really done justice to what they have spoken now. Well, the TVT study does look at the Barwell versus the trap, and they looked at patients who have either had a failed trap or a previous cataract surgery. So from the IOP point of view, they found that in the first 3 months, the trap was lower, after which there was no significant difference. And at 5 years, both had nearly the same success rate. Even with regards to medication, they found that both at the end of 2 years follow-up were evened out in both of them. The failure rate, well, the trap was a little higher when they looked at IOP at around 21 millimeters. The reoperations were more in the trap, nearly 29% as compared to 9% in the tube. Vision loss was again the same in both, and so were complications, which was slightly more in the trap than in the tube. But again, that was in the first month, after which they all evened out. So is trap superior? Well, no. They have shown that it is not superior. We need to look at the patient profile, as both Monica and Rupali have said. I would tend to go in favor with Monica and say that yes, I would rather do a trap first, but I would look at the cause of failure, look at the patient profile. Those which are at high risk, say NVG or a pseudo exfoliation, yes, I would prefer to do a tube first. But look at the cause of failure, as she has very elegantly pointed out. There has been a study by the Arvind group where they looked at the, in 2019, where they looked at these surgeries of traps with mitomycin, and they did have good success rate. Cost, yes, a big factor. The cost of a tube is much higher. So look at the age, look at the mobility of the conjunctiva, look at the risk factor, and if they all fall in favor, go ahead with the trap. Otherwise, what?
Thank you,